Hello. Thank you all. That was wonderful. It was amazing talks from everyone, as expected. And we have a lot of questions coming in from the live audience that's watching all of these talks. But I know some of our speakers are on a little bit of a time crunch here, so I'm going to take the liberty to get started a little bit and direct some questions to Dr. Pollack. One question was regarding the imaging. You had mentioned, the importance of good cross-sectional imaging, and you mentioned your own preference for MRI. So there was a question: is that something that should be universal, or is there a place for CT scans as well?
Yeah, thank you, Dr. Mittal. I really appreciate the opportunity to be part of this great panel. I don't know. My experience has been, it's been a little bit institution specific. I don't know if Dr. Zhang or others can comment on MD Anderson, but when I was a fellow there, it was very CT heavy. And then when I went to Hopkins, we were very MRI heavy. And now at Ohio State, I tend to favor using MRI in my own practice. I just think, with cholangiocarcinoma, more hilar than intrahepatic, but having MRCP capacity. I also think just having the different images, T2, T1, diffusion weighted images, it just provides me more data when I'm trying to do a preoperative assessment. So I favor MRI. Obviously, there's no radiation with MRI also.
Yeah. I think I absolutely agree. I think a lot of it's institutional dependent, practitioner dependent, and radiologist dependent in terms of what you have to read. Another question for you: you mentioned neoadjuvant therapy, and you mentioned your selection criteria for neoadjuvant therapy, particularly those high-risk factors such as size and lymph node metastases and things like that. But then you very elegantly showed some great work on, the NGS in terms of prognostic factors associated with some of the NGS profiles, and then the machine learning that you're doing. So how do we evolve our criteria for neoadjuvant therapy prior to resection? Should all patients get it? Should it only be on a clinical trial? Or how do we really push the envelope for selecting patients for that, Dr. Pollack?
Yeah, that's a great question. So, I don't think it should only be on a clinical trial, because I treat many patients with neoadjuvant now. I think as I mentioned in my talk, I use factors that I think are associated with high risk of recurrence, of multifocality, hilar lymph nodes that look positive on MRI or PET scan. But I think your point is well taken. I mean, I personally do think that we're headed towards perhaps treating all of these patients with neoadjuvant therapy. At least the data that we have from our international collaborative, it would suggest that, many of these patients recur very early, like within 6 to 12 months of their operation. And half of them will recur extrahepatically with they may have intrahepatic disease, but half have at least one side of extrahepatic disease, which suggests to me that many of these patients have systemic disease at the time of presentation. And many patients with intrahepatic cholangiocarcinoma require a pretty significant hepatectomy. And even in the best of hands, there is some morbidity associated with that. So I think for me, analogous to colorectal cancer and even, pancreas cancer, as we're getting better with our systemic chemotherapy, I think we're going to be moving more and more to introducing that perhaps earlier in the algorithm to treat these patients. Because as I always say to patients, it's not the disease that I can see that I'm worried about, right? I can cut that out. It's right. The disease I can't see. So I favor neoadjuvant.
Perfect. Chingwei?
Thanks, Tim. So on the topic of surgery, I want to give Dr. Gabriel a chance to talk about transplant. Certainly, we're not having any head-to-head right now in terms of surgery, resection versus transplant. How would you, if you looked at your patients with HCC and other reasons for transplant compared to ICC, how do they do in terms of morbidity of their surgery, in terms of their liver and how they do it?
Well, it really, at the end of the day, it depends on thank you very much. This is a good question. And, comparing cholangiocarcinoma to hepatocellular cancer, I feel I'm reliving the last 20 years for hepatocellular cancer. When we first started, the outcomes were very bad, and about 30%, 50%, about 3-year survival rates. And that's partly because it was the liver issue. Then gradually we learned what to do with the hepatocellular cancer. At a certain point, there was a moratorium of doing hepatocellular cancers, and only came after Mazzaferro wrote the famous New England Journal of Medicine paper that you get about 85% 3-year survival. And then gradually we learned, we added local regional therapy, and then we shrink tumors, and actually working with MD Anderson, you very well know. I mean, we do tumors greater than UCSF criteria, with very good results. So I think we're going through the learning curve of transplantation. However, because so far the first line is resection, we've maintained that we'll do it to patients with very advanced disease or very or multifocal. So I would just like you to imagine if you have a 5-centimeter tumor that came to us responsive to chemotherapy from the get-go, and there was a way to give them a transplant, perhaps a living donor transplant, we're probably going to be starting to look at a change in how that disease is looked at in the future.
Yeah, Dr. Hamill, regarding the pump, there's questions about the toxicity of it. Like what do you anticipate? What is the grade 3-4 toxicity of the pump? And I also have a question in the phase 1/2 trial that was done between MSK and WashU. Why the choice of GEM-OX versus GEM-CIS?
So to start at the end, the GEM-OX versus GEM-CIS was just timing of the chemotherapy. GEM-OX is the timing worked better than GEM-CIS did. So that was the reason for that. As far as the grade 3 and 4 toxicities, the huge majority of toxicities are just, lab value, usually increases in liver function tests, things like that. Only 4 patients out of the group had grade 4 toxicities that required them to come off of the trial. So about 10% of patients. There's probably about 20% of patients that have some form of lab abnormality, but it's pretty well tolerated.
Perfect. But I think it's exciting that you have a R01 funded trial coming up between a couple of the institutions. That'll be great to see. Dr. Zhang?
Yeah, I think that, when we move on past surgery, I think oftentimes what I see is it can unfortunately be a dealer's choice based on what institution you're at, right, in terms of the local therapies we discussed today. And I'd like to kind of hear the thoughts from each of the speakers who were, I guess, assigned a topic, obviously, about I'll talk about the pros, but what are some of the cons for the type of ablation or SERTs or radiation therapy? Bruno, you want to start? What would be something that you would say should go to one of your partners in radiation to do instead?
Thank you so much. Can you hear me?
Yes.
Thanks so much, Dr. Zhang. I think from our perspective, what we ideally try to categorize those patients based on essentially 2 things: the size of the tumor that we have to treat and the location. So if we're talking about a small tumor in a peripheral, safe location away from the major hepatic vessels and bile ducts, I would say that ablation should be the modality of choice. If we're talking about a tumor that it's centrally located, it's hypervascular, and would not be safe to do ablation, I think would be a choice between transarterial radioembolization with yttrium or external beam radiation. What drives our decision between transarterial radioembolization and external beam radiation? It's essentially 2 things: how vascular the tumor is, and the multifocality of the tumor. So we're talking about several tumors. Probably radioembolization would be the way to go, because we can take advantage of the hypervascularity and try to maintain liver function without exposing enough too much of a normal liver parenchyma to radiation. If we're talking about a central hypervascular large tumor, I think we opt to go to external beam radiation. But as you mentioned, I would like to also hear from the other participants on the panel about their opinions.
Sure. So, Julian, what are your thoughts about what would be a contraindication to using SERTs?
I don't think, there are contraindications. Obviously, high level of bilirubin produce high toxicity for SERT, so you need to be aware of that. And even in case of previous biliary stent, we showed that you have high toxicity with SERT, so you need to keep a patient with low bilirubin level. Apart from that, I think there are
different types of local regional, and you need to have different approaches for each patient, and this is always a multidisciplinary decision to go to the right treatment. And obviously ablation will be for low volume lesions. Then for radiation and SERT, you may treat higher volumes. And when you have very diffuse, I think only arterial hepatic infusion of chemo can safely be done. So there is a continuum, and for each institution you will discuss which treatment seems the most appropriate for your patient.
And Maria, your thoughts on the radiation? I know Chris Green's data says, turn up the juice, it'll work better. But what are some contraindications from your standpoint?
So I agree with Dr. Edelin. Biliary function, so the liver function, is key in helping us select what's the best treatment to consider. So getting good, adequate biliary draining is a priority before considering any treatments. And then there is the continuum of the small lesion to intermediate lesion to large lesion, and the location of each of these, which we discuss in the multidisciplinary team to select the best treatment for that particular case. I think with the problem we have in cholangiocarcinoma, we don't have a one-size-fits-all. And the fact that we've got so many people on the panel with so many tools just highlights how challenging it is to treat this disease, how we all have to work together to find the right treatment.
We have just a couple minutes left. I'm going to ask two questions, one to Dr. Edelin and one to Dr. Hawkins. Dr. Hawkins, there was a couple comments on the chat asking about what are the indications for proton therapy. So in a second, if you could address when should we use proton versus other modalities. And Dr. Edelin, I was very interested with the trial using SERT with chemo in the first line setting. And you reported a median OS of about 22 months, which is not that different from other series and single center series versus with obviously selected patients who actually progressed on first line chemo or got SERT on as a second line. So what are your thoughts in terms of with your trial? Is SERT really ready to go first line with chemo, or should we still be reserving it for after, or is there a toxicity problem? So maybe we could start with Dr. Hawkins and we'll end with Dr. Edelin.
Okay, thank you. So protons are tiny particles from the center of the atom, and how they are different than the X-rays is they produce a sudden burst of energy when they stop, and they don't transverse through the normal tissue. So in that way, they cause very little damage to the nearby healthy cells. So in cholangiocarcinoma, the nearby healthy cells are liver cells. So in larger lesions where there is the normal liver, functioning liver is small, protons would be beneficial. For lesions which are 3 centimeters or less, ablations or surgery has such excellent results, they should be considered. Thank you.
Okay. Dr. Edelin?
This is, of course, a very important question, and obviously we don't have many data on that. What we can see is when we are looking at a series of SERT given in second to later lines in chemo-refractory patient, you do see some good series, but you also see very bad series with survival less than 1 year. And results are more homogeneous when you look at series with only first line. The second point is a very high disease control rate that we achieved. And I think 98% disease control rate is really major. And we achieved that in first line. And I'm not sure any other treatment can achieve that in second line. The last point is the potential for downsizing to surgery. And we have, with this technique, quite high percentage of patients that can be downsized. And I really feel that providing this opportunity soon in the treatment pathway of the patient offer higher probability to discuss back with the surgeon whether we can resect this patient after treatment. So I'm a proponent of first line chemo cert with concomitant chemo, but well, only well-designed trials can clearly demonstrate that.
Perfect. Well, it looks like we are out of time. I think with such a fantastic panel, we could easily go another hour asking great questions and is gleaning so much knowledge from all of you, but we are out of time. It's been a long day. So thank you all. And on behalf of all of the speakers and my co-moderator, Dr. Zhang, thank you all for a great session. Very much appreciate it. And we'll turn it over to Dr. van der Bernstem and Stacy for closing.
Thank you.
Thank you.